So thank you for joining us for our webinar series, How the Built Environment Impacts Resilient Healthcare Systems. For those who don't know me, I'm Natalia Ranzolin, a postdoc research fellow at the Australian Institute of Health Innovation. I have just completed my PhD co-tutel in health innovation at Machry University in Australia and in civil engineering at the Federal University of Rio Grande do Sul, Brazil. My main advisors were Professors Tarcísio Saurin and Robin Clegg Williams, and my thesis proposed a framework of built environment design knowledge supportive of resilient internal logistics in hospitals. I will be chairing this session along with Inger and Leo, and will briefly introduce the webinar topic and our speakers. Research on patient safety underscores the role of the physical environment in facilitating or impeding work performance in health systems. So to improve design for safety, engagement, and cognition, we need to understand the functional and environmental factors in acute care hospital design, such as how the layout and interior design of settings such as ICUs and operating theaters can impact flow disruptions, risky behaviors, and social interactions. So Herminia and Laura kindly have joined us for a discussion on the role the built environment plays in resilient performance and better healthcare delivery. Herminia Machry is an internationally licensed architect with a PhD in planning, design, and the built environment. With 18 years of experience, she has worked on healthcare facility projects, taught at universities, and conducted research in healthcare and evidence-based design. Her research focuses on improving safety, engagement, and cognition outcomes in healthcare environments, particularly in ICUs and operating rooms. Her significant contributions include designing operating rooms, NICOs, and doffing spaces for COVID-19 ICUs. She joined the University of Kansas as a tenure-track assistant professor in interior architecture, continuing her human-centered and evidence-based design work. Laura Cambra Rufino is an architectural doctor accredited in the evidence-based design process. Specialist in research on healthcare architecture, Laura is currently researching alongside health personnel in the Invest10 unit of the Carlos III Health Institute, thanks to one of the grants, Margarita Salas. Her doctoral thesis focused on the evaluation of hospital architecture and was funded by a FPU contract from the Ministry of Education, Culture, and Sports. And now I would like to introduce you to Herminia. Please, Herminia, the stage is yours.
Well, thank you so much for inviting me to participate in this webinar. I'm really pleased to be with this community of Resilient Healthcare Society. What I'm going to talk today is a little bit about my professional journey and how it relates to resiliency in healthcare systems. But it's definitely my perspective, so take everything with a little grain of salt. But I think, it was quite interesting when Natalia asked me to join, because I don't usually think about my work as work in resiliency, but I think it's quite related. So I just a little bit about myself. I would say that my journey was really from thinking of architecture as a macro thing, large healthcare facilities, to now really doing my research on the interior of spaces in these healthcare facilities. So I think I started doing, practicing. I'm trained as an architect in the south of Brazil. And then I moved to São Paulo, did my master's, and it was really all about, I was really driven by the complexity of these hospitals and how, to put the puzzle together and the efficiency of these buildings. And then I moved into, okay, let's talk about patient experience and evidence-based design. And that's how it all really moved and shifted to the interior of these spaces. So I think I would just want to say that I think really the beginning of my career, I was really, intrigued by how hospitals were complex and were, these big buildings that renovated themselves and expanded. And that was really intriguing because I thought there was a real problem with creating mazes in these hospitals. So I think that's really how my master's thesis, like my master's kind of was born, because I was really thinking that, it's not great architecture when you have these large buildings and you have to follow a color line on the floor, right? That's not good architecture. So I was like, why is that happening? And then that's when I realized that I think a lot of that is because of technology and medical technology, how it evolves so fast, and these buildings have to kind of change to incorporate that. So this was one of the case studies of my dissertation, of my master's dissertation, and also, my research, but also a place that I worked extensively. So I spent 10 years in Sao Paulo, and I did several projects in the Clinic Hospital, which is a large hospital that was founded in 1944 and is still really a national reference in Brazil. And, has, of course, had, countless expansions and renovations. And I actually was a witness to all of that. So, and this was part of my master's research, where I followed three large hospitals through 30 years and saw how they grew, right? How they expanded, not only outside but also inside. And of course, I'm not going to go into detail about this research, but just share with you kind of the major things that I learned. So, I followed 30 years of this transformation in the buildings, specifically focusing on areas that I thought were really, driven by technology, like imaging departments and these outpatient areas that not only they are really transforming, but they're also the public, right? Where people actually need to know how they navigate the space. And I think a lot of my conclusions were really about the circulation structure of these buildings and how that is so important in when we plan buildings, to plan that right, so that it evolves in a more, in a less disruptive way. So I looked at, this is the first hospital in the Clinic Hospital. Then I looked at the Albert Einstein Hospital in São Paulo, and then the one of the Sada Kubitschek chain of rehabilitation hospitals. Again, very different hospitals, but it was quite interesting to see how they developed differently, right? So these two hospitals, they kind of followed like a basic structure, as opposed to this one that really became a real maze, right? So what did I learn about all of this? I think it was quite interesting to look at the work of one of the architects of the third case, which is the Sada Kubitschek chain of hospitals, João Figueiras Lima Lela. If you haven't seen his work, please do. I think it's really very insightful for architects. And it was basically, all of the things that we know today, which is, okay, you have to have flexibility. You have to have, the ability to expand, but in a way that is in tandem with the infrastructure. So circulation and infrastructure, that was a major lesson learned, that those two need to go together in hospitals. And if you want to plan how the circulations, the hallways are going to expand and lead to new departments or new areas, you also have to think of how the plumbing is going to go with it, all of the air ventilation and so forth. So, and another, of course, lesson learned was modularity, which, Lilad did brilliantly, I think, which is not just the modules of the building, but also of the ventilation system. And basically everything in this building is modular. And again, if you haven't seen his work, I'm not going to go into much detail, but please take a look. It's really great for thinking about resiliency. So another major lesson learned in terms of flexibility was the connection between hard and soft spaces in healthcare facilities, and how you definitely want to have a strategic planning and placing these types of spaces adjacent to each other. Because if you are, for instance, on the left here, you have a radiation therapy room, which is very hard, right? A lot of complex systems supporting this room, hard walls and concrete and all of that. as opposed to, you know, a waiting room or even an office that doesn't require all of that. So those soft spaces are easily moved around the facility when you need to expand. So definitely place those kind of together so that the hard spaces that are really hard to move around can actually expand and be moved around. So that was really my work in Brazil, right? So then I moved to the US. I did my PhD here at Clemson. And I really, you know, got to experience evidence-based design, which completely changed my perspective on architecture. And I used to think that, oh, I'm in love with big scale and big buildings, and suddenly I'm now studying the inside of an operating room. And in my research, I was trying to look at some units and ended up in a room. So it was quite interesting how that changed. But I think I still now I see and I think, okay, that's because yes, the patient experience is really a lot about the interiors, right? The evidence that we're looking for in these hospitals, which is infection control and outcomes and patient experience outcomes. They have a lot to do with the inside of these spaces. So I think one major thing that I think about evidence-based design that really changed hospitals and how they transformed, they had to transform to be, I think, up to date, is how we went from these wards, these shared spaces, from the Nightingale ward, which is pretty famous. That was a huge advancement. But then we moved to, okay, let's think about these spaces and maybe subdivide them. And then we had semi-private inpatient rooms or infirmaries. And then we had also open bay ICU, right? The intensive care unit where every patient is in the same room. But now we're actually here, right? Of course, this is an extreme. This is an extremely large patient room, private, but we're definitely moving to private. And I would say that, this is pretty much now a standard in the US. And I do believe that I think it's all over, right? In Europe and Brazil, I just visited the clinic hospital, that big, large hospital that I was talking about at the beginning, and they are all renovating their units, not only the inpatient units, but also the ICUs to be private. And I think the pandemic showed us that, right? Like we need to plan for isolation, to be able to not just privacy, but isolation for infection. So, and this is all based on evidence, right? Like we know that private rooms are better for infection control. They avoid cross contamination between patients and privacy. That's a huge requirement now from patients, and because they want to have visitors, sometimes they spend, in this case, for instance, this is a neonatal ICU, they spend months here, so they need a space to be there with their baby or to receive relatives. So of course this is a huge shift in hospitals because it requires so much more space, but that's where we are, right? Like that's how we've been changing to adapt. uh, so I wanted to share some of the work that I've done in neonatal ICUs. This was my doctoral dissertation, thesis. I don't know how you call it, because in the US is dissertation, but then it's really a thesis, so I don't know. But anyway, my research in my doctorate was about neonatal ICUs and the specific rooms, right? So in this, I saw really firsthand the transition, because we went from wards where the babies were all close to each other in this room because of infection control, because they thought families and parents coming in was an infection hazard, until evidence showed us that no, actually nutrition is critical for these babies, and skin to skin care. So no, let's bring those parents in, so let's allow them to be in the space and provide a chair for them. But then we went further, and now we're providing these private rooms because they need to be there. They are welcomed and encouraged to be there 24/7, not just an hour in the day as visitors. And that's where we are now. So we're now with these rooms, and my work right now is really investigating how the design of these rooms is supporting all of the complex tasks and behaviors that are happening inside this room. Um, and and this is kind of a little aligned with the work that I did in operating room. So in the work that we did at Clemson University in operating room design was very intensely understanding what happens inside this particular room. And again, a huge evolution, right, in terms of operating procedures and how these spaces kind of changed to support those different findings that we have in terms of surgery. And this was some work that I did in ambulatory surgery rooms. We observed 35 surgeries and tracked all of the surgical flow disruptions that happen in this room. One of them being on the screen, which is pretty daunting to think that somebody is, there's a tripping hazard right next to the patient being operated. But I think what was really fascinating was to see how much design actually can impact this work, right? In this particular project, again, there's various publications about this work. You're welcome to take a look or ask me about it later. But it is really about, simple things like the position of a surgical table in the room and how it opens up space for circulation, and it creates an environment that is easier to flow and to, go in and out to get, surgical equipment and stuff like that, or how a mobile workstation is so much better because it allows the circulating nerves to flow in the room more easily. So this, I'm just, bringing snapshots of this work to show you how really my perspective changed to see how, the layout of the room or small details inside a room can actually have a huge impact in how people work and how, in how outcomes come about in healthcare facility design. And that we definitely need to be resilient to address those things because, medicine changes so much. And I think if we're thinking right now, I think one of the major issues we have right now in terms of resiliency is staff retention. And I'm hearing that not only from clinicians, but also from architects, like, hey, we need to address this in design. How can design affect this? And what I have to say about this is my work on ICU rooms for NICU for COVID-19 patients. I did this with Georgia Tech when I was doing my postdoc, not like Natalia is right now in her postdoc. I did this work and we visited 4 units that were treating COVID-19 patients. And it was really all about staff safety and occupational health, because it is about, it's so stressful for them to be going in and out of these rooms all day. And what we were looking at was how they are able to, remove their PPE, their personal protective equipment, gowns and gloves and masks in a way that they felt safe and that they wouldn't, be contaminated. And what we learn, again, going from macro to micro, right? Like, this is how micro we got, because it is about this tiny space in the doorway of a room that is where they're doing all this work, and how to facilitate that. How can design, place things in a different way in these environments and allow space that is outside from the hallway so that they're not bumping into other people, which is a hazard, right? An infection hazard. So just to show you a little bit of how small we can get, right? Like, it's the location of these storage areas in the walls. It's where we dry reusable, masks or our face shields. Is where we have a sink, where we have a place to clean things that we're using, because that's what we faced in COVID, having to reuse these things. So I think with all of this, I just want to conclude with this. I think this work that I've done, this is the work that I'm doing right now, really looking deeply into the inside of these spaces and how there's so much to learn. I'm always amazed by how much complexity happens in terms of, patient care inside these rooms, and how there's so much to be done about, hey, let's actually learn how people do these tasks so that we can design for these tasks and have spaces that are more efficient. And I just want to highlight how much I find corridors really fascinating in healthcare facilities, and how much little they have changed over time. Yeah, they're a little wider, but there's so much that happens inside corridors, and there's so medical rounds that happen in these corridors, their equipment storage and so much. And now we had, this COVID that really highlighted these corridors. So I just want to, that's something that I'm interested in. And I think there's need for more work there. But that was all for me. I'm happy to answer any questions after we're done with all the presentations. Thank you.
So I would like to introduce you to Laura. Please, Laura, the stage is yours.
Thank you very much, Natalia. Can you see my screen now?
Yeah.
Okay. So thank you and hello to everybody. I'm very glad to be here at this webinar. My name is Cambra Rufino and I'm going to present my contribution to the topic how the built environment impacts on healthcare systems, resilient healthcare systems. One second, you are sharing the screen? I mean, you are seeing this, right? Natalia?
Yeah, it's okay.
Okay, because it changes something, okay. I'm an architect, as Natalia said, and I work as a postdoctoral researcher at the School of Architecture at Universidad Politécnica de Madrid in Spain, with a contract financed by the European funding program Next Generation. And before I start, I would like to reflect on the title of the webinar, because to address it, I would like to focus on my training and the Spanish context, the hospital circulation areas, and as Herminia said, and finally, the design of neonatal intensive care units and its impact on family engagement. Because the goal I've set myself for this presentation is to share research initiatives on the hospital-built environment within the Spanish context that could potentially influence healthcare resilience. For this reason, I've organized my presentation in three parts. Firstly, I will talk about my local context, my training, and the Spanish perspective. Secondly, I will show you a study on hospital circulation areas, and finally, another study on neonatal intensive care units. So let's start with the first part. I was born in a city in the region of Valencia, and in 2005, I started my studies in architecture. After graduating as an architect, I moved to London, where I worked for the international consultancy ARU in the vertical transportation team. In 2015, I decided to return to Spain and to study the impact of the built environment on people's health. So I started a PhD on the architecture of hospitals that was funded by the Ministry of Education. In 2018, I did a placement at the Center for Healthcare Architecture at Chalmers University in Gothenburg, Sweden. And after the stay, I returned to Madrid to finish my thesis, which I managed to defend in 2021. Here you can see the front page of my thesis, which focuses on the evaluation of functional and environmental factors in Spanish acute care hospital design. This was the visual abstract, and the methodology was based on mixed methods from 4 different perspectives. Firstly, from the theory, with the analysis of national standards, international guidelines, and also scientific articles. Secondly, from practice, with a 3-month placement in an acute hospital to carry out a lot of observation and to interview users. Thirdly, from the perspective of the future, with visits to hospitals considered as best practice. And finally, from the perspective of the present, with evaluation of 7 different hospital wards in 4 different hospitals. The result of this work was the evaluation Turcurar, which consists of a checklist of the design requirements that should be met at each room of the selected wards. The main motivation for this thesis was to generate research on the current design of Spanish hospitals in use that could be incorporated into the practice and into the new designs of hospitals. In Spain, the healthcare system is public and it's financed by taxes, and it is also decentralized. So the system is organized independently by each of the 17 regions of the country, with a national institution responsible for its coordination. However, until relatively recently, Spain had a National Institute of Health responsible for the design and maintenance of healthcare infrastructures. This institute had its own specialized architects, but the closure of the center led to a loss of specialization, and there are no clear research directions in the field of healthcare architecture nowadays. For this reason, we will continue with the second section of the presentation in order to learn about research initiatives that are progressively being carried out. The first study I would like to share with you has been published in the Spanish journal EGA and is entitled Multidimensional Graphical Model for the Analysis of Flow and Circulation in Hospitals. The aim of the study was to develop a methodology for the graphical analysis of the flows that take place within a hospital. Here you can see the external image and the representation of the study case. We analyzed architectural layouts to define the type of units on each floor, and we also specified which kind of users were allowed to access each unit. In this diagram, you can see that green is for everybody, outpatient, relatives, inpatient, clinical staff, and non-clinical staff. Orange is the same, but outpatients. Then we have red dark for clinical and non-clinical staff, and black for only non-clinical staff. We then linked each access to the hospital with the destination units, and we visualized different flow paths for outpatients in green, inpatients, clinical staff, and non-clinical staff. The overlapping of the paths allowed us to identify potential risk locations where flows intersect. For example, when the outpatient area was not all together or when the different flows types overlapped. Even though we didn't link this study to healthcare outcomes, in the next study, the last one about neonatal units, we did manage to link design variables to healthcare outcomes. This study has been carried out in collaboration with neonatologists from the Hospital Universitario 12 de Octubre in Madrid and has been recently published in the Danish journal Acta Pediatrica. Neonatal units were introduced in hospitals in the early 20th century to care for premature or sick babies thanks to the incubator invention. Initially, these units were designed to mimic trade fairs where incubators were displayed. As an example of this architectural layout, we can see this one where we have an access area, the main corridor, and then several clinical spaces with open bay rooms for multiple beds or incubators. And also we have this corridor at the perimeter of the open bays, which was originally designed for relatives, for parents, but which was obviously in disuse and used for storage. As survival rates improved, long-term effects such as cognitive and behavioral problems of newborns were highlighted. And in the 21st century, the developmental care model emphasized the need to reduce stress in newborns, considering the unit, environment, and stressor itself. Skin-to-skin contact with the mother was found to be optimal for the newborn, and the presence of parents in the neonatal unit led to a change from open bay rooms to more separated spaces, such as the single family room. The single family room is a room for a baby with a bed for the mother or the relative. These distributions present several benefits, such as reduced length of stay, reduced nosocomial infections, and increased parental involvement. But it also has some inconvenience, such as difficulties in staff supervision or isolation of families. In order to know the existence of single family rooms in the neonatal intensive care units in Spain, we sent a survey to all of them. In this graph, we can see when the units had been opened and the date of their last refurbishment. So, for example, there were 4 units built before 1965 that were very recently renovated. It is worth noting that also some of the very old units were not renovated, and also that there is an upward trend in the renovation of units. This diagram shows the type of wards where neonatals are cared for in intensive or intermediate care and basic care. As you can see, open bay wards are still predominant and single family rooms are still very rare in Spain. And finally, this table shows that units with single family rooms have higher levels of family participation in different tasks, such as daily rounds, diaper changes, or nosocomial sepsis, which have a direct impact on patient safety and patient experience. So we have now finished with the 3 parts of my presentation. And to conclude, I would like to highlight 3 main points. The first is that it is possible to initiate a research career on this topic, even in a country with no previous experience. The second is the importance of considering the built environment as a variable that impacts on different aspects related to resilient healthcare systems. And thirdly, the relevance of multidisciplinary research teams to link design variables with healthcare variables. Thank you very much for your time and attention.